Hello, so this is a continuation of the previous lecture on posterior and secondary uveitis. So this is a part two of the lecture, and we'll be talking about the non-infective uveitis today. So I showed you a flowchart in the previous lecture also. So this is a similar one, basic approach to non-infective uveitis. So the first step is you identify the clinical entity based on the characteristic clinical feature, which I'll be discussing in the subsequent slides. You rule out infective causes. Systemic steroids here are the mainstay of the therapy, unlike infective uveitis, where antibiotics would be the mainstay of therapy. You can use IV methylprednisolone therapy in vision-threatening lesions, such as papillitis and macular edema. Use immunosuppressives with caution in recalcitrant or resistant cases, and you monitor the side effect of the treatment. So, a basic approach to a non-infective uveitis is this. Now, coming on to some specific clinical entities. So, sarcoidosis. A systemic disease characterized by infiltration of tissues by non-caseating granulomas. So you see, this is the inflammation of the parotid gland, right? An MRI of the same. This is that granuloma, the non-caseating granuloma that you see. And skin manifestation, so it is a multisystem disorder. This is showing you erythema nodosum. So there's something known as Hereford's disease or uveoparotid fever, where there is parotid gland swelling, cranial nerve palsies, and granulomatous uveitis between the age of 10 to 30 years. Now, coming on to the ophthalmic manifestation, the fundus picture, you will find choroidal granulomas similar to Dallen-Fuchs nodules. I'll show you a picture of Dallen-Fuchs nodules subsequently. And remember, Dallen-Fuchs nodules are not specific for sarcoidosis, okay? They are specific for sympathetic ophthalmitis, but then they are also seen in other conditions, one of which is sarcoidosis. They are also seen in VKH disease, right? So there is vitritis and periphlebitis. So you see there is a mild vitreous haze and periphlebitis. Periphlebitis means a vasculitis that is confined to the veins. You see this? Severe cases, candle wax drippings. Candle wax drippings. Now, these are the candle wax drippings. Basically, there is an inflamed blood vessels and there is exudation from it, which is yellowish in color. So that looks like a candle wax dripping. Complications include cystoid macular edema. In this case, there is you see a macular star sort of pattern. There can be epiretinal membrane formation, intraretinal bleed, vitreous hemorrhage. Again, all the complications and all the types of posterior uveitis are similar. Revised criteria of IWOS for the diagnosis of ocular sarcoidosis, you can go back and read, you'll find it in any opthal book. Okay, so these are the criteria to diagnose ocular sarcoidosis. That's your candle wax drippings for you. Investigations, again, tailored investigations for sarcoidosis, chest x-ray to see granulomas, gallium scan of head neck mediastinum to see other, glandular swellings. Serum ACE is elevated in case of sarcoidosis, lysozyme, biopsy of skin or conjunctival nodules if present. A negative tuberculin test is specific for sarcoidosis. Treatment consists of steroids, and steroids. Okay, if steroids are not working, immunosuppressives. These are the immunosuppressives. TNF alpha inhibitors are some new ones. Coming on to sympathetic ophthalmitis. Now, this is a rare bilateral granulomatous panuveitis that occurs following a penetrating injury or surgical trauma. The eye that is traumatized or damaged is the exciting eye, and the fellow eye is the sympathizing eye. This is believed to be an autoimmune reaction to antigens in the uveal tissue, uveal pigments, or retinal antigens. Most of the cases occur within 3 months, and 90% of the cases occur within 1 year after trauma to the other eye, right? So basically, it has been seen that the exciting eye, there is persistent pain, irritation, and redness, and evidence of initial trauma would be there. For example, you may see a scar. Now, in this case, this was probably the exciting eye, right? The sympathizing eye, that is the other eye, develops sudden onset pain, photophobia, watering, retrolental flare, mutton fat capes. Remember, it is a granulomatous type of uveitis. Iris nodules, posterior synechiae, secondary glaucoma, and it ultimately may end up into a phthisical eye or phthisis bulbi. If prolonged, old signs of iridocyclitis or exciting eye may have shrunken but return of inflammation. This means sometimes even the exciting eye this could also be a case where this was the exciting eye, the left eye was the exciting eye. Just by looking, you cannot say, okay, now here, for example, in this picture, the right eye seems normal and it is the left eye that is affected. Now we don't know. So even this may have been an exciting eye, which has now gone into a case of phthisis. And uh, active inflammation is noted in the right eye. Okay, or this may be the exciting eye and simultaneously the left eye has, undergone a fulminant course and has ended up in phthisis, right? The posterior segment, this is what the posterior segment shows. There are small yellow deep white spots. These are the spots. These are known as Dallen-Fuchs nodules and these are scattered throughout the fundus. Remember, Dallen-Fuchs nodules can be seen in sympathetic ophthalmia. They can be seen in VKH as well as in sarcoidosis. Perivasculitis and retinal edema, these are the complications. Again, complications are common to all posterior uveitis. Now, this is a Dallen-Fuchs nodule. Okay, so you will find in histology, you will find which is going to be similar in both the eyes, albeit asymmetrical but similar. So, nodular aggregation of lymphocytes and plasma cells scattered throughout the uveal tract and retina. Now, this is a non-specific finding of inflammation in any tissue. Now, pigmented epithelium of the iris, ciliary body and choroid proliferates and along with epithelioid cells, which are basically modified macrophages and normal macrophages, they form these nodules, right? So this is basically a nodular aggregate of these cells along with the pigmentary epithelium of the iris, ciliary body and choroid. And these are known as the Dallen-Fuchs nodules. Treatment. Therapeutic, intensive therapy with topical subtenon injections, systemic corticosteroids, again steroids, because it is an autoimmune reaction. You have to suppress the inflammation, which you will do with steroids. Immunosuppressives in steroid-resistant cases. Preventive, prompt and meticulous closure of all penetrating injury. Any penetrating injury which has involved the uveal tissue or any intraocular surgery where the uveal tissue is enmeshed in the wound is a risk factor for sympathetic ophthalmitis. Now, this is relatively rare nowadays because of the availability, the wide availability of steroids, and because of good surgical techniques. Now, if the injured eye is unsalvageable, enucleation should be done within 2 weeks. After 2 weeks, it's not going to help because the sensitization to the uveal antigen has already happened. So we do an enucleation. Now, as I said, it is very, very rarely required these days because injured eye being unsalvageable is rare. With the advent of new techniques, new machines, new knowledge, we hardly have to enucleate an injured eye. Okay, but in the cases that we have to, that is the cases which are PL negative, there is no useful vision and it's a painful blind eye, we have to do a enucleation. If doing enucleation, you have to do it within 2 weeks. Beneficial effect of enucleation of exciting eye after the development. Once the disease has developed in the contralateral eye, there is no role of enucleating the exciting eye. Next, we have BKH syndrome, the Vogt-Koyanagi-Harada syndrome. Now, the name is because it's after 3 scientists who discovered 3 different presentations. Vogt discovered poliosis and ocular inflammation. Harada discovered the posterior uveitis with exudative RDs, and Koyanagi discovered the skin and hair depigmentation along with the iridocyclitis, hence VKH syndrome. It is a severe pan-uveitis associated with cutaneous, neurological, and auditory involvement, most common in the Japanese, related with this particular type of HLA. And I already told you, these are the extraocular lesions. What about the fundus lesions? Here again, you'll find Dallen-Fuchs nodules. You see these nodules over here? These are the Dallen-Fuchs nodules. The condition is bilateral, so there is a bilateral pan-uveitis. Multifocal exudative choroiditis, exudative RDs, optic neuritis. A sunset glow fundus is basically once these lesions are healed, there is a depigmentation that happens, and that is known as a sunset glow. There is a depigmentation of the entire fundus, and there is a optic disc in the center which appears red, and the rest of the fundus appears darkened. That is a sunset glow fundus. And Segura sign is basically an anterior segment sign. It is perilimbal depigmentation. That is the Segura sign. Treatment is again steroids, cycloplegics, and systemic corticosteroids. So remember, there is an element of anterior uveitis also in this particular entity. Next, we have white dot syndromes. Now, these white dot syndromes are a group of inflammatory chorioretinopathies in which the common defining feature is the presence of multiple discrete white dots located at deeper retina and choroid. Many of them are associated with a viral prodrome, but etiology is lacking for these conditions. They are rare. They are seen in young, healthy adults. They may lead to these symptoms, again, common to all posterior uveitis, mostly acute in onset, transient, and long-term visual consequences are not there. So examples of a few white dot syndromes, right? So all of them have in common the presence of these white dots with or without active inflammation, with or without associated vasculitis, floaters, pigmentations. The common thing is these tiny white dots. Okay. Then we have masquerade syndromes. Now, masquerade syndromes are non-uveitic conditions that behave like uveitis. For example, lymphoma, secondary malignancies. So, if you find that there is a non-resolving or atypical presentation of any particular type of uveitis, not responding to antibiotics, not responding to systemic steroids, or an atypical presentation of a particular type of, for example, toxoplasma or specific other specific type of uveitis, you have to suspect a masquerade syndrome. They are especially seen in immunocompromised patients, such as HIV patients. In children, the entities, the systemic conditions which cause these masquerade syndromes are leukemias and retinoblastomas, while in adults, they are malignant melanoma and metastasis, right? So masquerade syndromes, another common cause of posterior uveitis. Now, just a little bit about endophthalmitis and panophthalmitis. So endophthalmitis is severe intraocular inflammation involving the ocular cavities and the inner coats of the eyeball. Now, post-operative endophthalmitis, commonly seen post-cataracts, not commonly seen, I'm sorry, a rare entity with an incidence of less than 1%, may be seen after cataract surgery, which is the most common intraocular surgery. That is a different entity, and this one's different. Okay, this I'm talking about. I'm endogenous endophthalmitis mostly. So infectious versus non-infectious mode of infection, post-traumatic, post-surgical. This is the one I'm talking about. This is a specific type. It is a different entity. Endogenous can be via blood or metastasis, and secondary spread can happen via adjacent structures. So remember the definition of endophthalmitis, and that's the pus in the anterior chamber or hypopyon. Clinical features, this is what the eye would look like. It's an inflammation of the inner coats of the eye wall. So the sclera is spared. There is edema, congestion, KPs, there is hypopyon, abnormal, there is a white reflex because there is exudate behind the pupil. It can end up in a phthisis bulbi or no PL. Management of endophthalmitis, including the acute post-op, is very energetic and prompt. You have to take a TAP for culture sensitivity. And before TAP, and then you have to start broad spectrum antibiotics. The TAP is usually taken during at the same time as you're giving an intravitreal injection. Intravitreal injection is a type of targeted tissue delivery of the drug. It directly goes into the vitreous, right? So it is acting on the infected site, whereas eye drops would not be that effective. So intravitreal injections are given. So you take a TAP first, then you give the injection, and then you start the patient on broad spectrum antibiotics. And when the TAP results come, you can modify the antibiotics accordingly. So in intravitreal injections, you have to give a combination of drugs that cover gram positive, gram negative, and anaerobes, right? So usually we give these: gentamicin, cefazolin, vancomycin, or ceftazidime plus vancomycin. For antifungal, these are the two, and steroids is a plus minus. If you are suspecting a fungal or a tubercular endophthalmitis, you have to withhold dexamethasone until you start the specific antibiotic therapy. Sometimes, if the exudate is very thick, such that no, even intravitreal is not working, you have to decide to do a core vitrectomy. Early vitrectomy is indicated if the medical treatment fails to control in 48 to 72 hours, or if the vision is less than hand movement at presentation, or if it is a fulminant endophthalmitis that is progressing from day to night, rapidly progressing. You have to do a core vitrectomy in such cases. Remember, for a core vitrectomy, a pars plana approach is used, and I told you about the pars plana being the flattest part of the ciliary body, and the I told you about the vitrectomy being done in this particular region because that was the applied aspect of when I was teaching you uvea. Okay. So, panophthalmitis, this is the most severe form of inflammation of ocular cavities. It involves all the three codes, right, including the Dunant's capsule. So, etiology is more or less the same, but then it involves the sclera as well. This is how it presents. Severe pain with radiation, redness. There can be systemic features like fever also. These are the signs. You see, there is no PL in these cases, and there is severe, pus formation. The cornea is necrotic. It is opaque, and the globe may have perforated, and pus may have been extruded. End result is phthisis. Um, Treatment is evisceration to prevent intracranial extension. Okay, there is nothing else that you can do for a panophthalmitis because otherwise it's going to cause complications. It's going to spread intracranially and lead to cellulitis, orbital cellulitis, and cavernous sinus, and meningitis, and encephalitis, all of that. So the treatment is evisceration. The eye is already PL negative. So difference between evisceration, enucleation, and exenteration. Okay, so this is evisceration, right? Evisceration is basically like scooping out and leaving the scleral behind. So removal of the corneal button with scooping out of the intraocular contents, leaving the scleral cord partially or totally. That's evisceration. Enucleation is removal of whole of the eyeball, including the outer cord, after disinserting the extraocular muscles and optic nerve posteriorly. Usually around 1.5 mm of the optic nerve stump is taken along with the globe and the remaining part is left behind. Enucleation is the treatment of choice in cases of malignant tumors. Exenteration is the next step in which a highly malignant tumor may have to be removed. So exenteration is basically removal of the contents of the orbit. See, you see this blue line over here? So all of this is removed along with the eyeball, of course, right? So that is the exenteration. That is, contents of the entire socket are removed. The muscles, the gland, optic nerve, bones, periosteum, all of this is removed. That's exenteration. So it is important to remember the differences among the three and the indications. So thank you, and that is all about posterior uveitis, the clinical features, the differentials, investigations, and the generalized treatment of posterior uveitis. Thank you for watching, and you can always go back and revise on my YouTube channel.